Dr. Workman, we will hand it over to you for your presentation.
Yeah, thanks so much. I don't believe so. I think it's calendar year for the urine albumin creatinine ratio. I want to say it's calendar year, so I haven't seen that issue. So thank you so much for allowing me to come. My name is Bill Workman. I'm an internist by trade. I'm also the chief of staff for Bronson as well. And I'm talking about our Bronson Battle Creek practice here. And so the Bronson Battle Creek practice is really more or less in a suburban area, but we really touch the urban and rural area as well. Very close to those areas. So we really have a broad population. Our EMR is Epic. We have in that practice 5 physicians and 4 APPs. But what's really helpful is we have a strong team of other, people within that team that help us. So social workers, pharmacists, and care managers that work closely with us in our MAs. Our practice is employed. We do not have a lab on site, but we have 3 labs close to us in the area. We do collect our urines on site, which I think is very helpful if need be. As you said, it's very stable, so it can stay, in the fridge for 3 days. It can stay out for a whole 24 hours. Some issues that we have, seen here, our patient population. We really touch a broad population. We're in a suburban area, but we have a lot of urban patients and rural patients, so that can really affect, how we provide care. Transportation is a big problem for us, as well as low healthcare literacy and an impoverished population, which is not unfamiliar to many of you, and also lack of preventative care. We just don't have enough primary care providers in the area, and that's been like that for a while. So lack of access to those preventative services. So our rate here, as you can see, is 92.6%. That's 63 attributed lives. So our process, I think what really helps us is that we set the expectation, and this has been going on for years. I'm in practice for 10 years, and it's really ingrained in our patients way before this. But we really say, okay, you've got labs set for the next appointment. Please make sure to do that about a week before. So patients really expect this. So they'll, just go to the lab a week before, and we make sure that those orders that we put in for that visit that they're at are placed right then, because then they'll be on those after visit summaries. So then the patient will be able to see that. And something that's nice within our Epic EMR, it actually has started to remind patients to go to the lab if they haven't within that week time frame or whatever you set for the expected date. We also really educate our patients to the why. I think that's always important. People want to know why you're doing this. And really, we tell them, as you all know, it's an early detection for kidney disease. We can really hone in and make sure we're not missing anything in regards to your health, and then be able to treat you if we see those early signs of kidney disease. And again, setting these clear expectations and educating these patients has been helpful for us and for our providers. And as I mentioned, we have collection on site. So, like I alluded to at the first slide, we have a team-based approach. So we have care managers in our office, nurses. A lot of them are seasoned, so they really know how to help those high-risk patients. They follow a lot of our diabetics, CHF, COPD, and they can really educate those patients and take the time, and also reinforce testing and remind them to do testing if they forget. They also help us with our patient assistance applications for medications. I think this is key. There's affordability for medications is huge, so they can be able to help facilitate that process. Our pharmacists, we added them several years ago. It's been just a wonder. They are mandatorily referred to our patients. Any patient who has an A1C above 9, and they really are that extra touch point in between us seeing the patient. So I typically will see the patients twice a year, sometimes 3 times a year, but the pharmacist will be able to touch base in between, whether it be a phone call or a virtual appointment or having them come in. They can show them how to use CGMs. They can show them how to administer insulin and some of the GLP-1s and really help with that process. They also have a collaborative agreement with us so they can help with titration of meds and actually order testing. MAs, as you all know, are kind of the backbone of practices as well. We have them, we set an expectation that if they have time, I know it gets really busy, but they try to pre-chart on all our patients that are coming in, whether it be 2 days before or a week before, and they can actually remind those patients that have not gone to the lab to go. And then so that saves, kind of a missed visit as well. And then it's our role as physicians to educate these patients on the importance of doing testing, especially the urine albumin creatinine ratio and some of the other things. It's important for us to be able to track your health with these. And we have some dashboards that we use that are actually built into Epic, which I'll show in a second, that we monitor ourselves as physicians along with some of our other lean processes and lean teams to be able to make sure we're closing these gaps in care. And then I'd be remiss not to talk about our social workers because, again, these are actually one of the second to the care managers, but one of the resources or people that we added after. And for behavioral health, it's just really key, but they also help us with our non-compliant population, trying to break down barriers and getting patients signed up for an assistance program that I'll talk about on a later slide, and helping with the transportation issues as well. So, how do we track our progress? And like I had mentioned, we have some really nice dashboards, but we also have a clinically integrated network at Bronson that really partners with our ACO and trying to collect data and monitor data and help us with any process issues. They can focus in on some of those practices that may be falling behind or those providers that may be falling behind and share best practices. We also have a really robust PI program, performance improvement across most specialties, especially primary care, so that we can collaborate as a group and work on focusing on gaps and really standardizing best practices. Like I mentioned, we have these dashboards and reporting structures, which I'll mention and show in a second. And then we have something called the Bronson Management System, which is basically our lean management system, which we've had for a while. But we have what are called L1 huddles or tier 1 huddles. We have a tiered approach to the management system. And so we have a group within each of our offices that is kind of that local expertise that interacts with the tier 2 and tier 3 huddles to be able to focus in on the gaps within the practice that might be missing. So this is what our quality dashboard looks like. It's built right into Epic, and you can see for internal medicine there, those are the metrics that we're focusing on for the year. And it gives you percentages and kind of shows you how you're doing throughout the year and then year to date. And you can see there we have the kidney health evaluation that we're talking about here. That includes the GFR as well as the urine albumin creatinine ratio. And so something that's very important is, transparency and being able to drill down to the patient specific level and be able to see who's falling out and why. And so, as you can see there, if you hover over one of those boxes, you can view the patients that are associated with that particular metric and be able to get a list, which I'll show in a second. But the really nice thing is anybody has access to these dashboards that has, Epic, or has access to our Epic platform. So that'll be providers, office managers, data analysts, our pharmacists, really anybody, medical assistants. So they all have a role in tracking that, especially our pharmacists. They look closely at this. And I think transparency really helps us to be able to close these gaps in care. It's kind of an expectation that the data is reviewed quarterly, at a minimum. It doesn't necessarily have to be the provider, but the lean team does for sure. And so, again, it allows us to be able to drill down to patient-specific level. So I think on the next slide, you'll be able to see this a little better. Yeah, so this is drilling down here. As you can see, the checkbox there, it means that we've fulfilled the metric, but then you get an X that says that you have not, fulfilled that. And there's other. We have some exclusions there that you can see, on the right side that you can look at. So then you can see, okay, why did that patient not have that urine albumin creatinine ratio? You can open their chart and kind of see what happened, and be able to target it on the next visit, or yeah, figure it out. So that patient level data is really helpful. So yeah, some barriers that we have, again, non-compliance and missed appointments, and I think the pharmacists have really, and care managers have really been a wonderful addition to help remind the patients to get labs, and really educate them on why it's important. And then our social workers, as I mentioned, really help with those missed appointments. If there's 2+ missed visits, within a time period, the pharmacist will reach out to the patient, or sorry, the social worker will reach out to the patient and then help to address those barriers that they may have. As can seen there, as seen next, we have some financial and transportation barriers as well, and so the social workers can really help with that transportation issue. But like I mentioned earlier, we have something called the Bronson assistance program, which patients who are underinsured or low income can receive either testing and lab services and visits for free, or at a subsidized rate. And we've had some help too with virtual visits. We do this a lot. I know there's some issues with regulation recently with virtual visits, but it sounds like that's been fixed. So hooray for that, so we can continue to help with those vulnerable populations. So next slide. Yeah, so a patient story here. So this will be typical for many of you, or kind of looking in the mirror per se. But an elderly male patient, came in, really no family support. High A1C. It really was much higher than 9. Was missing a lot of appointments, rescheduling. Did not have good insurance, lacked transportation. Just really social. All the basically social determinants of health were against this person. So our social worker arranged for this patient to have transportation. It was actually covered by their insurance. We connected with this patient with a Bronson Assistance Program, so they were able to get their labs, free, so they could say they had no worries about doing them, or worries about the copays for the appointment as well. And then we also, like I had mentioned, have the ability to collect the urine albumin creatinine ratios on site, and also A1Cs. We have point of care testing for A1Cs. So we did this for him at many of the visits to avoid him having to go to the lab. Our care manager worked with this patient closely for patient assistance programs, getting the patient, some assistance with insulin and GLP-1 medication, which all GLP-1s are really the hallmark medication for diabetes management, especially those really high A1Cs along with insulin. And so we were quickly able to use our pharmacist to titrate up that medication in between visits with me. And over, actually just a few months, we were able to reduce his A1C to less than 7, which is a really good goal for this type of patient, and really avoid all of the negative consequences that happen, both macro and microvascular, for this patient. So yeah, thank you so much. Oh, population challenges. Like I mentioned, there's some financial hardships there that we deal with, as well as transportation issues. And we all know that zip code really strongly influences your health, and access to health resources as well. So with all the different resources we have in place, I think this has really helped to improve the health of our population. So thank you so much.
Thank you, Dr. Workman. We really appreciate it. Dr. Ashman, I will hand it back to you to wrap us up.
Yeah, can you forward to the next slide for me? I just want to really appreciate our presenters, and I'm just so thrilled with the many happy faces and hearts that we're seeing. It was a lot of work for these presenters to put this work together, and as well for our team who helped with the amazing slides. And I think what's most interesting to me is the variety of different practice situations we all work in, and yet how so many different solutions helped you reach your goal, whether it was collecting urine on site or providing resources, whether it's a big or a small practice, employed or not employed. And I made a lot of notes to ask you questions, but they're really chicken scratch. So I'm going to keep them and ask anyone who has specific questions for our presenters. Would you please put those in the chat, and we can ask our presenters either in this next few minutes or after the presentation is over today. I love the ghost to respond to them. I am going to just wrap us up with these wonderful presenters who are achieving really excellent results in uACR testing and their practices, and how we can help you or help the collaborative as a whole to achieve better outcomes for our patients. One of the things we want to make sure that you're aware of is that we do have our data for uACR screening, but it's a little tricky where to find it. This is in the legacy patient data dashboard, which you can see here depicted on our data dashboard screen. And then, as you can see in number 2, renal details. So we're going to click on the renal details tab, and then you can see over in number 3, we can use our filters, and you'll see advanced filters, and it'll take you to uACR. So that's certainly how you can access your own data dashboard anytime, and we'll be sending out these reports for you with your improvement over time. As Jake said, as we start the year, we should all start with 0 patients having a uACR and move that up to 100% every year we reset. Next slide. And then finally, this is just one of the resources that we've been developing. So this is a handout for patients. Again, I think I just really appreciate Dr. Workman, the effort your practice goes to explain to the patient the value of the test. And Dr. Hoffman, I think this came up in our last regional meeting as well, that I guess I didn't put 2 and 2 together, that some of our patients really worried that we were doing drug testing when we're testing for uACR. And so just again, explaining to people what the purpose of the test is and what it does and doesn't do. This is a really great resource that you may want to use if you feel like it would be valuable, that you'd like an easy way to explain the value of tests to your patients. We already shared those best performing practices from our sites. We're partnering with the National Kidney Foundation of Michigan. So if you are lower performing, or you're having trouble identifying how you might close gaps or implement some of these strategies to change your workflows, the National Kidney Foundation of Michigan is providing us hands-on practice facilitation. So please reach out to us if you think that would be valuable for you. You're going to be getting those quarterly progress reports, and we'll be summarizing and sharing those strategies with you.